talk about countertransference. Some of you will remember that we were here last month. We were talking about transference. So in some manner of speaking, this is the counterpart of that conference. And it has, as you will see, some similarities and very important differences. It's indeed not less important than the subject of transference that we discussed last month. Countertransference plays an extraordinarily significant role in all forms of psychotherapy, particularly dynamic and governing forms of psychotherapy, and certainly in psychoanalytic psychotherapy. And it's, as you will see, is a multiple role that it plays. On the one hand, it helps, when well understood, helps the analyst to understand many communication of the patients that otherwise would be difficult to comprehend. And because they cannot verbalize it, they can't put it in words, but they can make you feel it by what they say and by their attitude and by a variety of different means that they use that makes you feel in a certain particular way. And very frequently that's a communication. It's a communication that appears. And it's related to the countertransference. Your response, if you pay attention to it, may tell you a lot about what the patient is trying to communicate, or the kind of experiences that he had that he cannot put into words, but he can make you feel them. Obviously, there are a number of other uses that the countertransference has, and it has, as you will see as well, it's a great asset, it's a potential danger for therapists. If you don't understand countertransference well, the subject in itself, if you don't look at your own countertransference phenomena with all patients, and particularly more so with certain type of patients that have a special ability to produce a very strong, intense reaction in you, then it might conceivably happen, indeed it happens possibly frequently, unfortunately, that they reactivate some of your own conflicts and you lose the ability to be objective. You are reacting now not to your patient in a neutral, understanding, objective, rational kind of manner. You are producing a response which significantly may be coming from your unresolved problems. Again, some patient has a special ability to find where your buttons are and know how to press them. And so it has any number of implications, as I'm trying to tell you. That's who I am, but most of you know me. We need that in any case for the purposes of the web page. Now let's countertransference. Countertransference, as you see defined on the screen, is really a psychoanalytic concept. It's understandable. It's a psychoanalytic concept that was discovered and developed by Sigmund Freud many years ago. It has, since that time, been amplified by many other analysts and other professionals, even in the psychotherapeutic field rather than in the psychoanalytic field. Though obviously the most important contributions, and perhaps the large majority of the contributions, have come from psychoanalysts. Yet what follows, that is the subject countertransference, has an enormous value for everybody in the field of mental health, for psychiatrists, for psychologists, social workers, psychotherapists, nurses, counselors, doctors, in general, really, or mental health workers, as indeed happens with many other psychoanalytic concepts. As I told you, the phenomenon of transference is a universal phenomenon, as we saw last month. It happens. It happens in all kinds of human relationships. The only difference is that analysts and therapists understand it and work with it and know what to do with it. But it appears in all kinds of human relationships. It appears in terms of your relationship to your friends, to your spouses, to your bosses, to your colleagues, and so on. And when it is very marked, as we saw last month, it can produce strange kind of interactions between the person producing this transference and the person that is receiving the transference, because he is given roles and being attributed intentions perhaps, or attitudes or feelings that they don't really have about this person at all, that they are transferred from the past. Countertransference has the same universal characteristic. It perhaps less noticeable for most of us, certainly very noticeable for people in the field of mental health, particularly those of us that work in psychotherapy with patients, and those of us that work in the psychoanalytic modality. But it appears in all human relationships, and perhaps one of the common expressions of it is when you say, I don't like that person. And you don't know that you should have met them. But something in your gut says to you, there's something about them that doesn't quite fit with me. Essentially, that's a countertransference phenomenon. They are obviously triggering things in you that are your own, and you are producing that response. It doesn't mean to say that that response is in itself inappropriate. It may be quite appropriate, because some people have a very developed sense of their intuition is highly developed, and they kind of foresee what is going to come in terms of that interaction with that particular person in the long term. So, as transference works, this is a similarly valuable concept, applicable everywhere, and in all kinds of situations at work, with patients, with relatives, and in professional organizations. Like transparency leads to a lot of problems. Only that in this case it's not coming from the patient to the therapist, it's coming from the members of the organization that are reacting to other people as if they were objects from their past. And if you are not aware of that, obviously that reaction can be a serious problem in the relationship or in the work of a particular group or a particular organization. Now, I told you that this is a somewhat old concept. It was developed by Freud quite some time ago. As you see, it was in 1910. It's going to be close to 100 years. That Freud said the following in a paper that he called The Future Prospects of Psychoanalysis. This is a quote. He said then, and this is the first time that this phenomenon is described, we have become aware of the countertransference which arises in the therapist as a result of the patient's influence on his unconscious feelings. Arises in the therapist as the result of the patient's influence on his unconscious feelings, and we are almost inclined to insist that he shall or she shall recognize this countertransference in himself or herself and overcome it. At this particular point in time, he was particularly concerned with the limitation that such feelings will pose in the psychotherapeutic treatment of your patients. If you are not aware that you are producing reactions that may essentially disturb your ability to understand in an objective manner your patient, and you be mixing, you know, with the patient's problems and feelings, your own problems and feelings to some degree. He further say in the same publication that and of course, remember, he was writing as an analyst, so he's talking about analysis. He says, no psychoanalyst goes further than his own complexes and internal resistances will permit. Which means, if you have certain type of conflicts and problems, it's not very likely that you will see them clearly in your patients. Or even if you see them in your patients, your view of them may be somewhat blurred and distorted by the fact that you are adding to whatever the patient is showing you your own contribution from your own psychic conflicts and problems. He further say, and this is a quote again, we consequently, move this forward, we consequently require that he shall begin his activity with a self-analysis and continually carry deeper while he's making his observations on his patients. That may be a possibly an interesting quote to you, but remember the date is 1910. At such times, training of psychoanalysts was not organized the way it is today in institutes and people having their own personal analysis and so on. Essentially, people were doing what was called a self-analysis. Now, in the reality of it, that Freud was very good at it because he discovered the whole issue of psychological conflicts and emotional difficulties and things of that kind. But most of the human beings were not in the same level that he was in understanding these kind of problems. And so self-analysis is possible now, particularly for people who have been in treatment before. And so when they terminate, they are very familiar with the process, and they can, in the quiet of their own studios or rooms or in a couch anywhere, take a little time and free associate in relation to the kind of difficulties and problems that they may be confronting at that particular time, or in relation to the feelings that a certain type of patient may want to have provoked in you in that particular occasion or that particular day. This is highly recommended today, and most analysts that I know that are worth their salt do this commonly and frequently. It's very useful. I highly recommend it. Now, anyone, this is still Freud quoted from the same publication, anyone who fails to produce results in a self-analysis of this kind may at once give up the idea of being able to treat patients by analysis. In other words, if you don't have the capacity to introspect, to face your ghost honestly and directly, and that's very difficult to do. It's easier said than done. If you don't have that capacity and that kind of will, then you are not very likely well suited to look at other people's problems and conflicts. Because in this very special kind of relationship that exists in the psychoanalytic process or the psychotherapeutic process between the patient and the analyst, the limits are sometimes blurred, and there are some degree of merging, which you may or may not be fully aware that it is happening. Obviously, if it is something very obvious and severe, you will notice that, but it frequently happens in manners that are very difficult to identify, and yet it's extraordinarily important for you to keep constantly watching what is coming from you vis-a-vis what belongs to the patient. Countertransference, and this is one of the dangers of it, which is what Freud is really trying to say at this point, may lead to blind spots in their work with the patient. And that it will do. And of course, this can happen to anyone. In fact, it will be impossible for somebody who is practicing psychotherapy or psychoanalysis not to have on occasion a patient that will provoke certain type of reaction in you and who may provoke some blind spots in your ability to perceive the patient in an objective manner. And some of the merging will make it even more difficult to know what belongs where, and so it can get very, very confusing. As I said, if you train yourself and you know yourself somewhat, and most people in this field have had some form of treatment, and certainly analysts in the course of the training go through an extensive psychoanalytic process, and so they learn a lot about themselves. It doesn't necessarily mean that they become perfect human beings. That's not true. But they, at the very least, those problems that they are not able to resolve during the course of the psychotherapy, and many get resolved, those that they are not able to resolve are kind of faults in the building of in the edifice of the personality, the structure of the personality, that they are very aware of. In other words, you learn what your limitations are, what handicaps you are running as a therapist. Indeed, many therapists then on that basis will decide, and we do that, nearly everybody does that, what type of patient they are more inclined to see. There are people that only want to see certain type of patients. There are therapists that will avoid certain type of patients. They will see them for any reason at all. And very frequently that is a very rational decision, which is based in a reasonable knowledge of your own structure of the personality and how that will or will not tally appropriately with that of your patient. So Freud in those days, and we are talking, as I said, of 1910, at the beginning he recommended continuous self-analysis. There were no institutes at that point. There were no training analysts. The training of analysts was not organized as it became. Later on, a few years later, when that got better organized and structured, then he recommended not only the continuous self-analysis, but training analysis. Analysis every 5 years, Freud recommended. He thought that you, in this field, are frequently exposed to a lot of very difficult human tragedies and conflicts that are bound to reactivate your own feelings of whatever it may be, shame, guilt. There is a certain danger in being a therapist, and what he was saying is it may be wise once in a while to get yourself back into. It didn't mean that you have to be there for years again in analysis or anything like that, but enough to understand a little better and to get yourself out of what otherwise could become a somewhat difficult situation. And so that was one of his final recommendations. Obviously, people should be trained and should have, he said, a training analysis. Then he recommended that not only should they have a training analysis, but every so many years they should have another refresh kind of course, not necessarily a very long one, but a refreshing group of sessions. And of course, never forget that you need to constantly be doing some self-analysis and looking at your responses to your patients of whatever type they may be, and what the relationship of these responses are in relation to what you know to be your own conflicts and shortcomings. Now, for that reason, and this may surprise you, second analysis are quite common among analysts. I can tell you that the most analysts that I know that are distinguished clinicians and theoreticians have had more than one analysis. And by that I mean now not a refreshing course, but I mean long analysis with a couple of different therapies. They do that for a number of reasons. Some people may have some need because some things are reactivated in them, you know, and so they have a need to try and look at these problems, or some type of anxiety, guilt, shame, God knows why, or inhibitions of working, or depressive feelings, whatnot, may be triggered by the activities that they engage in with the patients. And so obviously that requires, some further work. So most of these people does it because in the course of treating patients, they understand that this is like climbing a mountain, and that the higher you climb, the more you see. And so though they don't have any particular problems, they are aware that they are happy, contented, maybe leading reasonable life, things of that kind, that they don't see as much as they would like to see, and as they see other colleagues being able to do, which means these colleagues have gone a little higher in the climbing of the mountain. And the way to do that is by means of a second analysis. And frequently that's very welcome, because your second analysis may have a completely different style, which may be more suitable to the type of problem that you have or had, and may give you, in some occasions, round up the process so that it's better. You are now more capable not only of enduring the difficulties that go with being a therapist, but at the same time you develop more of an ability to understand your patients and to be empathic and to use those feelings that are activated in you in a constructive manner. That's, again, is easier said than done. It's a skill, has to be developed. Some people are naturals about this. Most people have some gifts in that direction, and the rest they learn and polish. And then probably it's the same. They become highly sensitive to the patients. Now, there are many definitions of this, and I will read you some of them. It's not an easy concept to grasp, because it's like a diamond with many facets. All of it is a diamond, but it depends what facet you are looking at. That you see something slightly different, a little color, more light, less light, some inclusions in the diamonds, little carbon here and there, and things of that kind. Freud essentially was thinking of the reactivations of conflicts in the analysis during his work with patients, and that this may interfere with the analysis and lead to blind spots. And of course, he had a lot of experience with supervising people, and when the training became formally organized, he saw many of these problems in vivo, and so he was, acquiring more and more experience, and these recommendations that he was giving other people were important and were the result of his experience. Now, he himself obviously discovered the baby and made it grow, and so he didn't have an analyst himself, except that he was his own analyst. And his self-analysis never stopped. And he was awfully good at it, awfully good at it. And he did that from the very word go. If you read the interpretation of dreams, which was published in 1900, you will realize how skillful he was at reading his own unconscious and the conflicts that he had just by looking at how he understood his own dreams and those of other people at that particular point in time. That was only 5 years after he started to work in this particular psychoanalytic modality. As you know, he was a neurologist originally, and there was a significant shift in that particular direction. So as you see, in 5 years he has achieved a great deal, an enormous amount. Now, so that's one, the reactivation of conflicts in the analyst during his work with patients, and the problems that that can create in terms of your ability to be empathic, to understand your patient communication, to hold the reins of your inappropriate reactions like hurts to your narcissism or abusive comments by your patients, anger that they can trigger off in you, things of that kind. And so, of course, was the need to avoid serious blind spots that will essentially incapacitate you to help the patient, at least in certain areas of the personality. Second way of looking at it, and this is right, was the analyst transference to the patient. And this is like the reverse side of the patient transference to the analyst. Just like the patient brings from his past into the relationship to the analyst is luggage and attributes it to the present. This is another way of understanding the transference. In other words, the analyst brings the luggage from the past and mix it in the relation to the patient, maybe mix it with the luggage of the patient. Now, to avoid that 100% is a practical impossibility because human beings are not perfect. And nobody expects you to do that. What is expected of us is the ability to, of course, that this shouldn't happen very frequently, that you have done enough work about yourself and your difficulties so that it won't be all over the place all the time with all patients, but it will happen rarely and perhaps only with a specific kind of patient. And so, but on the other hand, it is, as you will imagine, not at all impossible, given the imperfect nature of human beings, that what the patient does to you, that is, that you become a substitute for his objects, the objects of his infancy, including his primary objects, that is his mother and his father, brothers, sisters, close friends, close relatives, grandparents, and so on. You do exactly the same. In other words, that patient will become a present-day substitute for an object of your infancy. And that's the way Anna Wright understood it. It's not incompatible with the other way. It's an amplification of the concept, as you see. And many people have done that. They have enlarged and amplified the concept and at the same time kind of define the complexity of it by adding several facets to the diamond. So if you are polishing it and more facets are there, so there is more light coming from it. And this is exactly the same phenomenon. Now there are others which there are other transference that I can tell you about, or other forms of countertransference. And this is Michael Balint, that was an English analyst, and Kemper. They hold this view. The whole of the conscious and unconscious attitude to his patients, or her patients, that may or may not lead to difficulties in his therapy. Now, slightly different, but as you see, it essentially embraces the same concept. The whole of your conscious, and this is not easy because this you are aware of, more important is unconscious attitude to your patient that you may not be aware that you have, that may or may not lead to difficulties in conducting the therapy of your patient. Again, there is nothing perfect about any analysis of therapy, but there is an obligation to aim for that ideal of cleaning the things so that you are really dealing with your patient and are not bringing your own past into that relationship. The fourth way of looking by this was by an American analyst, Max Gittelson, was very well known in his day. He's not there. And that he defined it as a specific limitations on the psychoanalysis that are brought about by particular patients only. In other words, he focused it and did not include all the reactions to all patients, but he preferred to focus it more and said the limitations brought about by particular patients only. That I think is a very restrictive way of defining it. But on the other hand, it's another facet of the diamond, because there is no question that there are certain specific type of patients that will affect us more than other patients. As indeed, I told you a little earlier, some therapists and some analysts avoid certain type of patients. They know that they don't like to work with them. They know they don't do well for them. And a lot of that has to do with their own inner makings. Another one is the appropriate. The appropriate, so it's not a neurotic, it's not a conflictual. It's not the reactivation of your neurotic conflicts that then are filtered down to your work with your patient. In this definition, is the appropriate or normal emotional response of the analyst to his patient. Clearly, we all react to the patient's communications in one way or another. And some of that reaction is objective and rational, and is based in your knowledge and your experience. Some of it is subjective and have very little to do with the therapeutic needs that that patient has. Again, if you have had sufficient training, which in this case, training in this field mostly means sufficient therapeutic interventions, trying yourself by an experienced colleague, then obviously you will have a better knowledge of all of this and a better control of it, and you are better prepared to avoid the difficulties that this could create and to be more thoughtful when you get into that area. It's like getting into a jungle where there are some animals that you are a little scared of, but you know that they are there and you watch for it and you are very careful where you tread and things of that kind. This is then an important tool to understand and to be empathic to the patient in this definition, because it is the appropriate or normal emotional reaction to the patient. And there is that, and there is the one that perhaps is not so appropriate or so normal reaction. Okay? And frequently they might be a little mixed, and they have to be separated and cleaned out. Now, obviously, if you look, we are back where we started. If you look at your reaction, what the patient has made you feel by his communication or his behavior, or by a combination of both, yes? And this is reasonably possible to say this is not coming from me, this is my empathic response to this patient, given the predicament at this particular point in time. That obviously gives you an understanding that words themselves cannot give you, because you don't feel it in the gut, This is an emotional response. It's like when many years ago there were no mathematician and philosopher called Bertrand Russell, an Englishman, was asked by somebody about cocaine. And he said, well, there are two ways of knowing what cocaine is. One is from reading it in books, and the other is from having experiences in your gut. And there is a difference between the two. Obviously, if you have the experience, you know something that the book can convey to you as clearly, And in this field, because we are all human beings and we suffer from the same developmental vicissitudes and conflicts as we grow up, and we all have a father and a mother, or at least many of us do so, and if not, we have substitutes and brothers and sisters and all of that, then we share really a treasure of common experiences, the human experience, which we all share. So this one is the one that is saying that you can use the countertransference. Not only have, you see the shift. Previously you were saying, be careful, you can't produce a reaction to the patient that is coming from your neurosis, your past. You may be treating your patient as an object of your infancy and things of that kind. This word and it can happen. But this word kind of warnings of the dangers. This one is telling you this is a magnificent tool that will let you understand your patient a lot better if you allow yourself to look at, to feel, first of all. Some people don't. Second, if you can put reins in these feelings, and you can use that constructively. The patient is communicating to you things that words cannot convey, unless they are accompanied by this response in the other person. Let's see, what else we have. Countertransference, as you see there, is as well a number of other things. It's an appropriate and normal response to the patient. The last definition that we read is in that kind of direction. It's a very useful tool for the treatment, obviously. Can be used to understand the patient communications, feelings, particularly in situations where words are not enough, where some empathic response or some feeling of special nature is experienced that conveys to you better than words could possibly do what your patient is going through. That is obviously of enormous value if you can rein it. And that concept of reining your countertransference is extraordinarily important. Now, I personally believe that there is a need to differentiate between those countertransference responses that are triggered off by the patient's conflicts, transference to the analyst, etc., from those behaviors on the part of the analyst therapist that would appear in the relationship to most patients, irrespective of what these patients do. I don't know if you see the difference that I'm trying to convey to you. There are, and this is related on the fact that there is a pure refined transference, countertransference, where you can use it in a very constructive manner, but it is very important to differentiate that from behaviors on the part of the analyst or therapist that appear in the relationship to most patients, which is irrespective of what most patients do. And that's important, because if you can identify that that is happening to you, you have identified that you have a problem that is not triggered off by a special situation of a particular patient, but is something that appears with every patient, and then you have to be very well aware that that's your problem and not your patient's problem. Unfortunately, we are not necessarily always objective enough or able enough to see, these things clearly. Now, that distinguishes between the analyst's own residual neurosis, which everybody has, every human being, no matter how good your treatment has been, and the more genuine light countertransferences. There is a gradation here where one may cross from the land of the analyst therapist neurosis to the land of the refined, pure countertransference. And I think this is important. And again, it's part of what we were talking about when saying you are in need of constantly looking at yourself, so-called self-analysis. Now, this is a little scheme for the different types of countertransference. You see, as you see, very similar to the transference that we described a month ago. There was, if you remember, a positive transference, a negative transference, there was a neutralized transference, which is kind of friendly, there was erotic transference, and so on. Well, the countertransference is not different, and that's why that definition that says that in a way it's like the counterpart of the transference of the patient to the analyst is when you see these particular types. This is not the more refined, in some cases, more pure type of countertransference, well controlled. Countertransference, obviously, if it is negative, that creates a problem. If you have a negative attitude to your patient, that creates a problem. Glover, Edward Glover, that was a very distinguished British psychoanalyst, called it counter-resistance. Just like the patient has resistances, this he called a counter-resistance. It's produced by the therapist. In general, so the countertransference are positive and negative, like the transference work. And within the positive transference, as you see, there can be a friendly type of transference, so you feel very well disposed, friendly like to the patient, but you have no other claims on that patient. In other words, there are no significant erotic components of aggressive components to it, or anger and things of that kind. So there is a friendly one, that's a friendly one. There is a neutral one, which means it's pretty cool, it's pretty decent, still very reasonable, and it doesn't necessarily lack elements of, friendliness or kindness, but it's a little more distance, which may be, particularly with some patients, a very good thing to happen. Now, some countertransference become erotic, and the therapist, analyst, may become sexually aroused by the patient. And that sexual arousal may go to any degree that you can think of, obviously. And is sometimes puzzling and painful to people who have this experience. Sometimes it is not. They go with the feeling, and unfortunately sometimes that leads to seductive behavior and on occasion to some very tragic crossing of boundaries, and with all the consequences that that obviously has, both for the patient and for the therapist. It's a catastrophic event, a real catastrophe. So that gives you an idea of the different types of countertransference. Now, Countertransferences are then, to summarize this, a very powerful positive tool, just like the transference phenomena is. And at the same time, there can be a very powerful interference with the ability of the analyst of the therapist. And you have to create a balance and watch particularly for this second possibility of it becoming a severe interference. Now, there are many things that you can do with this. When you are caught in a situation like this, that will happen to everybody sooner or later. Beyond your self-analysis, the possibility of going back and having a few sessions with somebody that you trust and has skills, you can go to a colleague and discuss honestly and objectively what the interaction was, what you felt, what you said, what the patient said, and a reasonable colleague that obviously is not producing the countertransference at that particular point in time may be able to help you see what you could not at that point see by yourself. Now, another interesting point about this, which I will discuss with you a little bit, is at the very beginning of the development of this concept, the statements that Freud made about countertransference were badly misunderstood. In a way, he was warning, be careful, he wasn't saying that it was bad, he was saying that the countertransference could, if not controlled, could create blind spots, could make a therapy a negative experience, could make it impossible for the analyst or the therapist to really treat that particular patient. And of course, then people felt that having countertransference was a bad thing to happen. Nobody wanted to say, oh, I have these negative feelings about my patient, so I get angry with them or whatever. People took it to mean that then your treatment, your own analysis, your own training hasn't been good enough. And of course, the most important part of training of an analyst is his own therapeutic analysis, their own training analysis. And so it means for some people, that's not what Freud meant at all, but it meant for some people that your own analysis was incomplete, that you haven't done well, that you have severe unresolved neurotic problems, or that you were not a good therapist or a good analyst, and so on. All they wanted to be in that group. Given the implications, of the original concept of the countertransference, that were really warning people about the dangers that it could carry with it. Just for a while, there was a kind of silence conspiracy. You didn't hear anybody talk about the countertransference at all, not at all. While in contrast nowadays, when people qualifies from an institute and applies to the American Psychoanalytic Association for membership and have to write the papers that are going to be looked at by a committee, if you don't have something about countertransference, they are probably going to fail you. Because everybody is now perfectly well aware of the enormous significance that it has. And they not only want to see the good, refined, pure countertransference, they want to see your raw countertransference as well, because they know, like any decent analyst know, that you produce them. That there's nothing wrong with that. But the problem may come is, what do you do with that raw feeling? And that we are going to discuss in a moment. But having the feeling is only a human phenomenon, and no one that has any experience in this field will believe you if you present a whole case and you don't refer to this, because they think you're lacking something. You are not, obviously, you can see this in yourself, what it means and what created off in the patient, and is that an important way of understanding how the patient manages to alienate everybody the way he's doing with you and things of that kind, then you are not in a position to be of great help to them. So there was this kind of silence conspiracy. No one talked about it. All this, of course, was partly linked to the myth of the perfect analysis and the perfect analyst, which is a myth. Nobody is perfect. You gain an enormous amount from analysis, and you gain an enormous amount from many forms of uncovering psychotherapy. Turn you into gods in, in their pantheon, the Greeks or the Romans or whatever. You are just a human being, and it has the same shortcomings that most other human beings have, only that you understand them better. You probably have taken away the sting of these problems and the mechanism of symptom formation that were derived from these conflicts, because you understand it better and you can see what significance they had in the past, where they may have been very appropriate, and how inappropriate they are at the present time. Now, who contributed greatly to this breaking down of the conspiracy, of the silence conspiracy, was this gentleman, Donald Winnicott. Winnicott in the 50s brought it out of the closet, so to say, in a paper that he called Hate in the Countertransference. That's something that nobody could or would have admitted before. Now, Donald Winnicott, I know him reasonably well. He was a teacher of mine in London, and he was a genius. So he was a very special kind of man, on top of which he had an integrity and honesty that was remarkable, very remarkable. He, of course, had a very interesting experience as a therapist. He was originally a pediatrician, then became an analyst, and he worked with children a great deal, though he was a training analyst, and so a lot of adults. He was the training analyst of many distinguished psychoanalysts in the world today. But because of that background and that experience, and you probably know the squiggles of Winnicott, he was inclined to take, for example, delinquent sociopaths that were raising holy hell in the street and creating all kind of problems into his home for a while, and trying to help them. And of course, this gave him a special feeling, given the way these kids could behave. And all child analysts will tell you that when you work with children, your emotions move a lot faster and come to the surface a lot quicker, because they really can provoke all kinds of things in you for a number of different reasons, including that they are very aggressive, they don't know the consequences of many of their behavior, and they destroy things, and they may hit you here, there, in the other place, in some places that you may not welcome, and things of that kind, and so you produce, if you are not careful, an enormous reaction. Let alone that there is a tendency to over-empathize with the child if the parents are not doing a good job, or are sadistic, or neglectful, and things of that kind. In any case, Winnicott, with this special genius and integrity of him, wrote this paper, Hate in the Countertransference. And he then described the strong negative feelings that do arise in the staff in the ward for psychotic patients. That's how he started. He was very clever. And he knew that if you put it in the context of psychotherapy in an office, a lot of people will not swallow this pill. It was a little too bitter. So he put it in that context, and that's the way he started the paper. So he kind of lubricated you in the direction of saying, yeah, I can see it there, and took you step by step This was obviously much more acceptable for professionals, and he further pointed out then, in the course of the same paper very quickly, that though mothers love the baby very much, there are times when they hate them. And I have put, not to be cruel to them or aggressive or really punitive and so on. Again, you see that, like the countertransference, is not acceptable feeling among most normal civilized societies. Mothers shouldn't have negative feelings for it, just like families shouldn't have negative feelings for their patients. But the fact is that we do, you know, and that in itself is nothing to write home about, as I told you a moment ago. It's what you do with this that is important. In that paper, Winnicott gave an enormously long list of the many reasons that mothers have to hate their babies. And I will quote you a few. If you haven't read the paper, I very strongly recommend that you read it. For example, he says the baby is a danger to her body during the pregnancy and at birth. You know, particularly up to very recently, childbirth was an enormous risky business, and a lot of mothers didn't make it through. That's not common nowadays, but it was not uncommon that people will die in the delivery. And maybe the baby will survive, maybe the baby will not, but not uncommonly the baby survived and the mother died. That was not an uncommon phenomenon. So the reality of it is, and remember, Winnicott did this in the 50s, in 1952, so in those days, all of these things were more common in terms of the frequency with which they happen than they are nowadays. The baby interferes with her private life. In fact, it takes away her life altogether because he demands so much attention and his needs are so intense that you just have to put aside a lot of things in order to satisfy his demands. So it interferes with much of your fun and your private life. He hurt her nipples by biting them, treats her as a scum, as an unpaid servant. She has to love him as Christian and all, he said. He tries to hurt her by hitting. He may refuse mother's food, but will eat with his aunt, you know. And so there are kind of reasons why the mother will get irritated by the children. And of course, when people wrote that, they read this, they say, yeah, I can see that's true. That doesn't mean to say you don't love the baby, but it doesn't mean to say that that's not all you feel. You have a lot of other feelings as well. And that broke the silence conspiracy. It became reasonable. After all, he said if a mother has this feeling for his babies, or for her babies, why do you think you analysts don't have this feeling for your patients sometimes? And that opened the door. Now, another important question in this regard is what we're going to discuss now. What use do you really make for the countertransference in therapy? For example, do you tell the patient what you may be feeling? Like, I don't like you, you are very disagreeable. Or you piss me off, or you are a bastard, you behave like a pig, or you make me angry, or whatever. Or rather, do you try to understand how he or she manages to make you feel a particular way, who you become in his head transference? And after that, you then pass to them a distillate of what patients can use profitably and constructively. There are people in both of these extremes. There are people who think it's a good thing to say to the patient, you are an ass. I don't think that's true. ever. Even if it's the case, it's not helpful to the patient in the slightest. There are people, as you will see in a moment, that will recommend that very, very strongly. Now, among those that recommend saying to the patient what you feel on a variety of different, on the basis of a number of different reasons, were among others Margaret Little. She wrote an enormous amount about countertransference, an English analyst, and I knew her very well. Winnicott, at a time in his life he changed later, Ferenczi, Sandor Ferenczi, and Balint. Winnicott had been referring mostly to his work with psychotic or asocial personalities, but occasionally so with neurotic patients. And I give you an example here. There are not many situations, this is a quote, in our ordinary analytic work in which an analyst's hate is justified. A patient of mine, a very bad obsession, was loathsome to me for some years. I felt bad about it until the analysis turned a corner and the patient became lovable. And then I realized that his unlikableness had been an active symptom, unconsciously determined. It was indeed a wonderful day for me, much later on, he says, when I could actually tell the patient that I and his friends had felt repelled by him, but that he had been too ill for us to let him know. And that appears in his paper in Hate in the Countertransference. It's interesting. As you see, he didn't do that at a time when the patient would have been badly hurt by it, but waited until the patient was significantly improved and his whole attitude has changed and he was now a much more likable person. Even so, I think it was a heavy dosage of oil castor, castor oil. Yeah? Now, other analysts, including Little and Ferenczi, not only acknowledge that analysts have a wide variety of feelings towards their patients, but recommended that they should at times express them openly. Alice Balint, Michael Balint's wife, which was an analyst too, suggested that such honesty on the part of the analyst is helpful and in keeping with the respect for truth that is inherent in psychoanalysis. And there's some truth in this statement. The respect for truth and honesty is inherent in psychoanalytic therapy, and it's a very important component of it. Yet, I don't think it's disrespectful to the respect of truth not to say things at a time that is inappropriate and where the patient cannot do anything constructive with it but feel simply hurt and further humiliated and guilty or ashamed or whatever it may be that the feeling is that is being provoked. Now other analysts, and this is now Paula Hyman, again an English analyst. The English analysts were very active in dealing with the countertransference. It's not my preference for English analysts because I trained there. It's that they were the people that really did a lot of work in this area. Hyman, Paula Hyman, very distinguished lady, psychoanalyst, well known, written a great deal, acknowledge, and this is a quote, that the analyst's emotional response to his patient within the analytic situation represents one of the most important tools for his or her work that he or she uses as a key to the patient unconscious. And that's true. That's the end of the quote. That was her view. But then she qualifies it and say, however, the analyst's feelings are his private affair, and she did not consider, quote, it right for the analyst to communicate his feelings to his patient. She was talking of both type of feelings, positive or negative feelings. Indeed, in her view, many so-called countertransference feelings require self-analysis on the spot. That's what she says. Requires self-analysis right then and there. And I think she was right. She was a very, as I told you, distinguished analyst and a very wise, experienced kind of analyst. She further recommended that our countertransference feeling be immediately checked out against the actual data of the analytic situation, the analytic section. And that is a very useful thing to remember. When you have these feelings, you need to check it against the actual data that has transpired during that particular session, and try and match what you feel with what has transpired, because frequently, obviously, it's not related to it, but it may have something to do with your response rather than with the patient's communication. Reich warned that countertransference may introduce, quote, something that is not inherent in the patient, but only in the analyst psychology. In other words, you are then putting into the patient things that don't belong to him, belong to you. It's a little bit what happens with some cases of sexual, so-called sexual abuse, where therapists kind of put ideas in the mind of the patient that had nothing to do with what really happened, and you know what that really leads to and what kind of problems it really creates. Now, she warned about the fact that something that is not inherent in the patient but only in the analyst psychology may be what is at play. Through the years, there have been many publications on the subject, but essentially there are variations on the above things. If you go to the internet, and you are a subscriber of the American Psychoanalytic Association library, you will find an inordinate amount of papers on countertransference, as indeed you do on transference. Essentially, this covers the substance of all these different communications and papers that have been written. So that should give you a reasonable skeleton of the concept. And I'm sure you may have some questions or perhaps some comments, or you may describe some of the situations that you have encountered yourself. And I think that's what I have for you today. So at the end of the lecture, maybe you have some questions, and I'd be glad to take them.